So good afternoon, ladies and gentlemen. My name is Justine Baqueta from France, and I'm moderating this session. And I'm really happy to introduce you Professor Marius Miglinas, who is an adult nephrologist in Lithuania, in Vilnius. And Professor Miglinas trained in UK and in Australia, and his main topic of interest are renal biopsy and glomerular diseases. And today he will discuss thrombotic microangiopathies after kidney transplantation.
Hi, my name is Marius Miglinas, and I come from Vilnius, Lithuania. I'm a head of a nephrology center here and also a center of rare kidney diseases. The topic today is about complement-mediated thrombotic microangiopathies after kidney transplant. As you all know, thrombotic microangiopathy is a pathological description, and the clinical presentation usually is thrombocytopenia, microangiopathy, haemolytic anemia, and organ injury. It's very interesting that nephrologists are involved very often in care of these patients because acute renal injury or in some instances chronic smoldering renal injury is very often, and extrarenal injuries are rare. In this regard, I would like to ask the audience, why do you think thrombotic microangiopathies are so tropic for kidney? Why glomerular endothelial injury is so often? And please answer the question now. The possibilities of answer are complement dysregulation, impaired hemolysis, or complement defective complement clearance. Okay, the majority of you answered that the disordered complement dysregulation. This might be true, but in fact there is ongoing research what might cause renal injury in thrombotic microangiopathies, and there is a work of several groups which show that glomerular endothelial cells fail to upregulate heme oxygenase 1, a major cytoprotective heme degrading enzyme in context of hemolysis. And just later on, this triggers complement receptor expression and downregulates complement regulating molecules on endothelial cells in glomeruli, and this explains the tropism of these injuries to the kidney. Now, over the last 20 years, there was a very dramatic expansion and advances in our understanding of thrombotic microangiopathies. We all remember the clinical classification of these, but now we have more understanding in what's going on, and thrombotic microangiopathies are being classified now as primary, which are hereditary and might be due to complement gene mutation or ADAMS13 mutation, or due to autoantibodies, either to complement regulating molecules or to ADAMS13. So a narrower term, atypical hemolytic uremic syndrome, is a complement-mediated thrombotic microangiopathy due to dysregulation of alternative complement pathway. In brief, the pathogenesis of the disease is when the acquired or inherited dysregulation of complement alternative pathway is either in the liquid phase, when the complement factor H or I are insufficient, or membrane cofactor protein, solid phase proteins are dysregulated. This leads to not regulated contact of C3b with endothelial cells and triggering inflammation, thrombosis, and tissue injury. There are a lot of secondary thrombotic microangiopathies, and this might be due to glomerular disease, malignancy, various drugs, autoimmune conditions, infections, and so on. So this classification shows that diagnosis is not easy. And may I ask now the second question, that when we find the cause for presumed secondary haemolytic uremic syndrome, this fully excludes the primary aHUS. Would you agree, disagree, or you are not sure? Most of you answered that you 70% that you disagree, 20% are not sure, and some agree. Those who don't agree are right, because 1/3 of presumed secondary aHUS are actually primary hemolytic uremic syndrome with a trigger. And this might be, this slide shows that this is true for pregnancy-associated aHUS. Even in malignant hypertension, 1/5 of patients might have different mutations. Systemic diseases also present with mutations. And in post-transplant microangiopathy, we have the same situations. Even in Shiga toxin aHUS, mutations have been discovered. So current hypothesis is that development of atypical aHUS requires 2 hits, a genetic predisposition and then the secondary hit. So the role of complement in thrombotic microangiopathies in some diseases is very clear. In some, it's unknown, or evidence. There is some evidence of complement activation, and complement-mediated atypical aHUS frequently only manifests upon exposure to a trigger, and these so-called secondary conditions could be that trigger. So coming closer to my topic, you can see that there are thrombotic microangiopathies, either de novo or recurrent after kidney transplantation. And the largest study evaluating post-transplant thrombotic microangiopathy is the United States Renal Data System, which studied almost 16,000 renal transplant recipients and reported incidence of thrombotic microangiopathies 5.6 episodes per 1,000 persons years. And this disease goes with a very high recipient mortality. In contrast to native kidneys thrombotic microangiopathy, post-transplant microangiopathy needs a renal allograft biopsy. So in any case, when there is acute kidney injury or slow progressive increase in serum creatinine combined with hemolytic anemia, increased LDH, low haptoglobin, and drop in thrombocytes and platelets, thrombocytopenia, we should perform a renal allograft biopsy. And then we should differentiate between recurrent disease, the same disease that manifests as a TMA in native kidney redevelops in the graft, or de novo TMA after transplantation, where the TMA develops for the first time in patients who have never had any evidence of the disease prior to transplantation. But this is very tricky question because the diagnosis of atypical aHUS may be missed in the native kidneys, and subsequently we could classify it as de novo TMA, but this actually is recurrence of the recurrent disease in the graft. Further workup should include whether the if we do renal biopsy and we see the signs of thrombotic microangiopathy, we should sort out whether there are systemic signs or disease is renal limited. If it's renal limited, we should rule out whether there is calcineurin inhibitor or mTOR inhibitor associated. We should search for infections, and of course we should look for antibody-mediated rejection. So kidney transplantation is a trigger for various forms of thrombotic microangiopathies because the transplantation itself leads to endothelial damage, brain death, ischemia, reperfusion injury, infections, immunosuppressive drugs, rejection. All that may exacerbate the disease and cause it de novo or recurrent. In terms of calcineurin inhibitor use, there are very interesting data showing that cyclosporin induces endothelial cell release of complement activating microparticles, and these are released from platelets and endothelial cells into the circulation. When these particles then can damage kidneys, glomeruli, as has been shown in this slide, where extensive complement deposition induced by injection of microparticles cause endothelial damage in glomerular endothelial cells. But there is a controversy whether it's true calcineurin-induced thrombotic microangiopathy, or it's just coincidence or triggering event, because more than 95% of renal transplant recipients receive calcineurin inhibitors, and only a small minority of them develops thrombotic microangiopathy. Discontinuation of this treatment it has not been consistently shown to improve long-term graft outcomes. So current hypothesis is that calcineurin inhibitors may trigger thrombotic microangiopathy if endothelium is already injured as a result of ischemia, reperfusion, injury, borderline donors, or there is ongoing antibody-mediated rejection or calcineurin inhibitor overdose. A very important consideration is antibody-mediated rejection associated thrombotic microangiopathy. There are a lot of data that this is very common cause of thrombotic microangiopathy developing after kidney transplantation. In one of the studies, over 6-year follow-up period, more than 50% of the patients with de novo thrombotic microangiopathy also had evidence of antibody-mediated rejection. In fact, thrombotic microangiopathy in C4D positive biopsies was 4 times higher relative to C4D negative biopsies. So this shows the importance of C4D staining donor-specific antibodies in differentiating these two entities. Now, regarding the testing, I have to say that most aHUS-associated genetic variants are rather predisposed to disease than cause it. Penetrance of disease is intermediate, and some patients will have more than one mutation. The risk haplotypes have also been shown to increase disease penetrance. And even with multiple genetic risk factors, triggers are necessary to develop symptoms. As you see on this slide, there is interplay between genetic predisposition and triggering events. If genetic predisposition is mild, we need a major trigger to disease to manifest. If genetic predisposition is severe, only minor trigger, even we don't know, even this trigger may cause the disease to manifest. And now I'm going to my question number 3. What do you think? Genetic testing is mandatory to confirm the diagnosis of atypical aHUS or not? Do you agree, disagree, or you are not sure? Right, more than 70% of participants disagree, and others agree or are not sure. And you are right that the majority of you are right, because the finding of no mutations in complement proteins does not rule out aHUS. Approximately 1/3 to a half of individuals with aHUS don't have complement mutations. And this makes this field very complex. The same story with complement serology. There are attempts to establish whether it's the decrease in C3, AH50, CFB concentrations, or to find increased complement cascades, terminal components, or activation products of complement system. And complement pathway assessment is a very useful tool to aid in diagnosis. But again, normal results don't exclude diagnosis of atypical aHUS. And there is one problem, that there is a lack of standardization in complement testing across laboratories. Now, regarding the treatment of manifestation of thrombotic microangiopathy after the kidney transplantation. If you diagnose the patient with post-transplant atypical aHUS, may I ask my fourth question? In your center, you start Eculizumab for patients with post-transplant aHUS as a first-line therapy, as a second-line therapy, only in those instances where there's typical aHUS is refractory to plasmapheresis, or you don't have access to Eculizumab. Okay, so 60% use Eculizumab as a first-line therapy, 25% as a second-line therapy, and 15% don't have access to Eculizumab. So this is very interesting, because there is growing evidence that we should start prompt treatment with Eculizumab. There is no time to waste, and because no biomarker currently will confirm the diagnosis of primary complement-mediated atypical aHUS in the acute setting. This is diagnosis of exclusion, and even before formal diagnosis is confirmed, we should start treatment of post-transplant atypical aHUS once we once we think that it's complement mediated. And only later on we should work on complement genetics, serology, and so on. In terms of plasmapheresis, there are American Society of Plasmapheresis guidelines published already 2 years ago, and you can see that plasmapheresis indication for plasmapheresis in transplantation-associated thrombotic microangiopathy or drug-associated microangiopathy except ticlopidine associated, these recommendations are not so strong. So how to administer the Eculizumab for atypical aHUS after kidney transplantation? There are various reports, various dosing regimens, but one of them is 900 milligram per week for 1 month, and then 1,200 milligrams every 2 weeks. As I said, it's recommended, there is growing evidence that we should not delay the treatment, and the treatment could be discontinued if alternative etiology is identified or genetic variants in the non-complement genes are established. Other question is how long to administer Eculizumab for aHUS after kidney transplantation. And again, there is no clear recommendations for the optimal duration of the therapy. There are reports which are time limited, for example, up to 6 months, or there are reports in Netherlands because of legal reasons up to 10 months. There are time unlimited protocols where there is no limit to access to Eculizumab therapy. And there is a question how to define the patient suitable for safe termination of the treatment. In terms of transplant setting, those transplant recipients who have lost previous allografts are especially not good candidates for treatment cessation. There is a very nice study performed by an international panel about outcomes of patients with atypical hemolytic uremic syndrome, both in native and transplanted kidneys, treated with Eculizumab. And as we can see from this slide, that the treatment duration should be around 12 months, at least 12 months to achieve the remission of thrombotic microangiopathy. Then to stop the treatment, for us should help complement activity testing. There are various methods described, like total complement activity testing, alternative pathway hemolytic activity, Eculizumab trough levels, and there are alternative assays like one developed in Bergamo, where in vitro human microvascular endothelial cell test is performed by trying to establish the complement activation at the endothelial level. So this might help in our making the decisions. But of course, when we know that recurrence rates are so high and we have a very poor response to treatment with plasma exchange, we should focus on the treatment, rather not onto the treatment, but to the prevention of development of atypical aHUS after kidney transplantation. So preventive measures are several of them, and one of them is that kidney transplantation should be delayed at least 6 months after the start of dialysis for various reasons. We should wait also for resolution in thrombotic microangiopathy features and extrarenal manifestations. There are historical reports for the patients with very refractory arterial hypertension that bilateral native nephrectomy could help. And of course, in specialized centers, combined liver, kidney, or isolated liver transplantation should be offered depending, but this is very special issue, and each case should be based on case-by-case basis, depending on type of mutation, availability of Eculizumab, and so on. And prophylactic Eculizumab is also being used, and this is based on the risk of recurrence, which depends on the genetic background of the patient. The risk of recurrence after kidney transplantation whether the mutant complement factor is membrane bound, which is a low risk, or circulating, where the recurrence after kidney transplantation is a high risk. So diagnostic algorithm for atypical aHUS candidates to renal transplantation should include the risk assessment. As I said, mutations in complement factor H high, C3 complement factor B, hybrid gene combined mutations, complement factor H polymorphism variants. We should start Eculizumab prophylactic therapy on day 0 with or without plasmapheresis. On the contrary, low risk mutations like isolated mutation of membrane cofactor protein and other mutations in non-complement genes or undetectable complement factor antibody, and in those instances where no mutations are detected, we could use no prophylaxis and go to the kidney transplantation. Of course, very important is, in addition to Eculizumab, to use other endothelial protective regimens to avoid kidney transplantation in preformed donor-specific antibodies positive cross-match, avoid extended criteria donors, and use low-dose calcineurin inhibitors or belatacept. And this should be preferred to mTOR inhibitors. And of course, we should use flu vaccination and monitor for infections. Very interesting presentation of thrombotic microangiopathies or other nephropathies which might mimic membranoproliferative glomerulonephritis is mutations in the acetylglycerol kinase epsilon. Loss of this gene function results in enhanced signaling through the arachidonic acid pathway, which leads to the activation of protein kinase C, and at endothelial level, this leads to regulation of prothrombotic factors and development of endothelial damage and thrombotic microangiopathy or various glomerular diseases. One member of our reference center, Karolis Ažukaitis, with colleagues, published recently a large overview of this entity. They analyzed 44 patients, 5 patients received renal allografts with no post-transplant recurrence reported. So probably these patients are safe in terms of no Eculizumab prophylaxis after transplant. Another disease is C3 glomerulopathy, where is no approved effective treatment, and where activation of the complement system is also involved, and there are C3 and also C5, C5a deposition in glomeruli, and half of people have kidney failure, and kidney transplant does not cure the disease, and relapsing disease is very common, but there are no data yet about the use of prophylactic Eculizumab in these patients. And the last thing about the donor, what do you think? This is my last question. In your center, transplantation from living donor is contraindicated for recipients with end-stage renal disease due to atypical aHUS. Do you agree that in your center this is contraindicated, disagree, or are you not involved in the transplant care? Okay, so majority, 44% think that living donor transplantation is contraindicated for these patients. Other 28% disagree, and they would transplant their recipients with end-stage renal disease due to aHUS from a living donor, and 28% of participants are not directly involved in the transplant care. So there are case series like this group study reported by a Dutch group from Nijmegen and Groningen. A case series included 17 patients with atypical aHUS who underwent living kidney transplantation, and this was done without prophylactic Eculizumab. And median follow-up after transplantation was 25 months. One patient had a typical aHUS recurrence, just one patient from 17. And at the end of the follow-up, for all the patients, the creatinine concentration was excellent at 106 micromoles liter and with minimal proteinuria. So the success of this strategy was that all living donors were genotyped. Cold ischemia time was short because this was done from a living transplantation from living donors, and low targets of tacrolimus were used. So nowadays it has been considered that a living donation for these patients is not contraindication. Again, a similar study, but from deceased donor kidney transplants reported by Bergamo group. There were 7 patients who received pre-transplantation plasma exchange, induction therapy with Eculizumab, low-dose cyclosporin, and no Eculizumab prophylaxis, and no relapse of this patient series with a median follow-up of 28 months. So in well-selected donor recipient pairs, independent, is it from a living donor or from cadaveric donor, this transplantation under close monitoring could be done even in end-stage renal disease recipients due to atypical aHUS. So even now there is a question that our paradigm should change, and should post-transplantation Eculizumab therapy change from a prophylaxis strategy to a rescue approach, like has been shown in these 2 studies. So I would like to summarize and conclude that genetic screening, although not 100% helpful, but should be performed ideally before kidney transplantation. And if it's de novo thrombotic microangiopathy, we still suggest to perform it after transplant. Identifying the underlying mutation allows us anti-complement treatment that can reverse the fate of the renal function. And the sooner the treatment, the better our results. But even better than treatment are preventive measures, either with Eculizumab prophylaxis or without, depending on genetic background of the recipient. And of course, in the context of living donation, we should perform screening of the living donors to rule out the asymptomatic carrier status of the same mutation which has the recipient, which is then contraindication to the living donation. But in the other instances, you can safely perform the transplants also for these patients from living donors. So thank you very much for your attention. Here I would like to finish my talk, and if there are any questions, I would be happy to answer.
Okay, so thank you, Marius. It was a wonderful presentation, very clear on this very complex disease. You may want to ask some questions, and you can type your questions on your board, and I will read them to Marius, so do not hesitate. I would have a question for you. I think it's really interesting to move paradigm from prophylaxis to rescue for Eculizumab after transplantation. As a pediatric nephrologist, probably for children, we may be more cautious. I think at least it's what we would do in our center. But in the Italian paper you just presented with, if I'm right, a factor H mutation, I'm very surprised that there is no recurrence after transplantation without Eculizumab, and maybe the follow-up was not long enough to see something. What do you think?
Yes, it's very interesting finding, and we know that the relapse, if it happens most of the time over the first 12 months. The median follow-up here was longer than that, but of course even later presentations are not uncommon. So the longer follow-up will we will find out on the follow-up, longer follow-up, what will happen to these patients. But it's very interesting that if you avoid extended criteria donors, if you avoid higher levels of calcineurin inhibitors, if you do induction therapy, this might be strategy which should be interesting.
Okay, thank you, Marius. And we have already one question from the audience. First, to thank you for this great talk. And then the question is, are you aware of studies that have assessed mutations in complement genes in CNI-induced TMA?
Yes, there are these studies, and my understanding is that there should be genetic predisposition, and the transplantation together with ischemia reperfusion injury, calcineurin inhibitors, the more triggers, the more likely the disease will manifest. So some of these patients, of course, there are studies that they have mutations in complement genes.
Okay, thank you. And we have another question. So I read it. Apart from theoretical arguments, what is the evidence for using lower doses of calcineurin inhibitors to prevent recurrence?
As all this field, there are no very strong evidence for that. It's just the case series reports, and of course no randomized studies. But again, speaking on the theoretical grounds, this sounds a reasonable approach, because, as I showed, calcineurin inhibitors induce microparticle release from endothelial cells, from platelets, which could then trigger the relapse of the disease.
Okay, and then we have a more practical question for you. So the audience would like again to thank you for this great talk. And it's a question from a pediatric unit saying that they have seen 2 children with living donor transplantation for acute or WT1 mutations, and both of them developed severe humoral rejection related TMA with de novo antibodies against Adams 13. And this clinical picture in both cases was resistant to daily plasma exchanges and Eculizumab. And so they ask you whether you already observed such cases and what you would recommend in this case.
Thank you, Olivia, for this question. I have to say that I am adult nephrologist, so maybe the members of our pediatric group we have more expertise in this, but of course the autoantibodies, patients with autoantibodies against Adams 13 we see very rarely, and personally I have not observed such a case, and it's very interesting that both of the patients are resistant to plasma exchange and Eculizumab, and well, it's very interesting. Maybe it's worth to try something else like Rituximab or other options. Thank you for asking this.
Thank you, Marius. As a pediatric nephrologist, I will not have any more comments to do on this topic. I do not see more questions at that time, and I think we are running just in time because it's been already 45 minutes on this fascinating topic. And I really would like to thank you again for this wonderful talk, and all of you who were able to attend this presentation. Thank you, and see you or talk to you next week with a topic on CKD MBD. Bye-bye and have a good afternoon.
Bye-bye.